Well, good morning and welcome to today's webinar, Alternative Payment Models and Value-Based Reimbursement. We're excited to have you on the call with us today. Before we get started, I'd like to go over a couple of housekeeping items. The first thing is that there will be no CPE credit offered for our webinar today. Secondly, the slides from today's presentation will not be available for distribution. However, the webinar is being recorded, and the recording will be made available within 24 hours. And finally, as an attendee, you are muted and in listen-only mode. But should you have questions during the webinar, you can use the questions pane to the right of your screen. Towards the end of the webinar, we will have a questions and answer section, but to help you along and ensure you don't forget any of your questions, you can go ahead and type them in as we go along through the webinar. So now that we've got those housekeeping items out of the way, I'd like to introduce you to our presenters today. First, we have Brian Hall. Brian is our CRI's healthcare industry leader. He attended Auburn University, and he has a lovely wife and 2 daughters at home. He enjoys fishing with his daughters and, of course, Auburn football. We've also got Bart McCurley. Bart is a partner in our Aniana office. He's got more than 12 years of experience serving long-term care facilities across the South. In his free time, he enjoys leading worship at his church. And then finally, my name is Mary Leslie, and I am the moderator today. I'm a Troy Trojan, and I've got a house full of boys at home. And now I'm going to turn it over to Brian so he can get us started.
Thank you, Mary, and thanks all of you for being here with us this morning. First off, just want to talk about the purpose of the webinar today and really what is happening in our industry. Healthcare as a whole is rapidly transitioning away from fee-for-service, which is the dominant payment model that we've been in for the last 30 years or so, and towards alternative payment models and value-based reimbursement. The goal of the payers is to align the reimbursements with value and to incentivize specific behaviors and reduce spend, which basically means they're going to use their dollars to purchase the type of quality that they'd like to see, and also to drive down costs. Fee-for-service really is on its deathbed. I know we hear that a lot. But you can see that there's been more changes to payment models in the last 5 years or so than in the previous 20 combined. So it's been a very rapid change. In fact, if you went on the CMS Innovation website, you can Google it and it'll pop right up. There are literally hundreds of models out there affecting providers of all types, models that are either in place now or will be effective in the future, or that they're even just considering. So it is really broadly applicable to everybody in our industry today. So the purpose of today's webinar is really to talk about what providers should do now to begin to transition away from fee-for-service, that world that we've all kind of grown up in. There are steps and logical, concrete steps that providers do need to take now. The biggest question that we'll get from a lot of our clients is, where do we even begin? How do we start? We don't have any experience with this. Or some of our clients will say, we haven't really done anything yet, or are we behind, and if so, how do we catch up? If that's the case, that's okay. That puts you in the majority. Most providers just simply haven't spent a lot of time or resources in this yet, but you have taken the first step. If you're on this webinar today, that means you are concerned about the changes in our industry, and you are being proactive, so we can help you get there. Bart, I think Bart will take us through a couple of topics for a later date and some timelines.
Thank you, Brian, and thank you everyone for joining us. Looking over the attendee list, we actually have a diverse group with us today. So our main purpose will not be to focus on that one specific provider or state, but we want to introduce that larger topic and have an ultimate goal of getting providers to start to think about how to get on this path for value-based reimbursement. In future presentations and communications, we're going to provide that more focused guidance when we'll take a particular type of provider or a specific regulation and delve even deeper into that topic and these may include the Quality Payment Program, the Medicare Shared Savings Program, Accountable Care Organization, Bundled Payments, and Skilled Nursing Value-Based Purchase Program. So, really, how did we get to this point? Medicare was originally designed in the 60s, and its existing models, which include the hospital and nursing home prospective payment system, they've really only had limited modifications for the last 25 years or so. As Brian said, the Medicare and Medicaid programs were largely fee-for-service models, and those focus on healthcare providers and service volume rather than the patients and the quality of services that providers give. As we know, Medicare is the largest healthcare provider in the country, and it's been paying providers for every service performed or ordered, and that didn't always improve the health of the patients or the program itself. The system, been rewarding treating the sickness rather than prevention of that illness. These alternative payment models, however, are designed to move away from this fee-for-service system and toward a more patient-focused approach, and the goal of that is the quality of services being performed, delivering that better care and outcomes, and even spending those healthcare dollars more efficiently. Alternative payment models are actually one of the few bipartisan ideas in healthcare. They were first promoted by the Bush administration, and when that Affordable Care Act was signed into law in 2010, it really only accelerated movement toward these models. And that's why the bipartisan nature of them is one reason why that shift has been so fast, and why we're really unlikely to see them go away. In January 2015, CMS published that accelerated initiative to move away from the fee-for-service models toward the alternative payment models and focus on paying providers based on that quality of care rather than the quantity of care. That initiative highlighted several strategies, including establishing that greater focus on better care, better health, and lower costs, engaging in accountable care and other alternative contracts based on achieving better outcomes, testing models to better coordinate care, and finally that relentless pursuit of improving health outcomes. They actually had an ambitious goal, was to have 30% of Medicare payments in alternative payment models by the end of 2016, and believe it or not, they actually met this goal by March of 2016. The next goal is to have 50% of Medicare reimbursement models in the alternative payment models by 2018, and have 90% of that linked in some manner to quality. So based on past performance, you can bet this goal is going to be reached well before the end of 2018. And I think with that, we have a poll question for you, our first poll question. When do you believe alternative payment models will have a significant impact on your organization's revenues? So we'll give you a few minutes to answer that, and then Brian will take back over.
Okay. If you'd like to go, we got a lot of votes registered. If you'd like to vote, go ahead and do that, and we'll get this finished out. Mary, go ahead. I think everybody's had a chance to vote, so we'll show you the results. Most people said either they are currently impacting us significantly, which I'd agree to, or in the next 1 or 2 years. So those are, I think those are the correct answers. So let's continue to talk just a little bit about the industry impact. Again, these alternative payment models are going to impact all provider types. No one is quote unquote safe from this change, from this progress. The models and the scope of it is increasing weekly. And maybe more concerning to everybody on the call is that we're not just talking about Medicare here. Commercial payers are very, very interested in following CMS's lead, and that includes Medicaid managed care. As an example, Aetna, the CEO of Aetna has put out a stated goal of having 75% of their total spend in some type of value-based contract by 2020. That is only a couple years from now. That is very concerning, and that shows that this is an industry-wide phenomenon. Additionally, there's been a parallel effort to expand transparency in healthcare, and CRI has put out some information on that. I'd encourage you to read it. I think it's pretty good. But if you think about that, that makes a lot of sense. From a payer's perspective, they can't gauge quality of the services provided without transparency into your quality and your prices and that kind of thing, and your costs. And so I don't see that going away anytime soon. And then also one of the biggest questions we'll get is what's the new administration going to do? Regardless of the new administration efforts and the new Health Care Act you may have heard about that came out yesterday or the day before, these initiatives are not likely to end. The reason for that is quite simply money. There's broad bipartisan support for this. The new CMS administration is in favor of alternative payment models. If you use the hip and knee replacement model for hospitals as an example, the first thing CMS did is take 2% right off the top of it and put it in their pocket. So just about without fail, every one of these models saves CMS money, and of course that's very attractive to the government today. So we'll go through a couple examples of alternative payment models. Won't spend a lot of time here, but we did want to talk about a few of the high points and show you how applicable this is. First one is the hip and knee replacement, what we call the CJR. This is important because it's the first mandatory hospital bundle started in 2016. Makes hospitals accountable for a 90-day episode of care beginning when that patient shows up at the hospital or that procedure is done. And of course, most of that 90-day episode is going to be outside the hospital walls. You know, whether or not that's fair, I guess we could have that conversation another day. That is what it is. And by nature, it forces collaboration between hospitals and post-acute providers. So think about your skilled nursing facilities, nursing homes, your rehab, home health, hospice, that kind of thing. The next one on here, CPC Plus, is a physician-based model that increases the quality and efficiency of care for primary care physicians. So it doesn't just stop at hospitals. And Bart will take us through a couple more.
Yeah, our next example is the Merit-Based Incentive Payment System, or MIPS, which involves nearly every physician or physician practice. And this was created by the Medicare Access and CHIP Reauthorization Act, or MACRA, you may hear it called, which created actually two pathways. It created MIPS and then the Advanced Alternative Payment Model, or Advanced APM. Together, they call these the Quality Payment Program, which the goal is to tie that physician reimbursement to performance by rewarding that high-quality patient-centered care. Actually, so this is kind of already in progress. The first performance period for this program began on January 1st of this year. Physicians can choose to submit data any time between January 1st and October 2nd, and performance adjustments will not go into effect until January 2019. But to avoid a negative payment penalty, physicians need to report at least one patient on one quality measure, one improvement activity, or advancing care information measure in 2017. And physicians who want positive payment adjustment, though, they'll need to report more than the minimum. The next one we have is the Nursing Home Value-Based Purchasing Program. And this was actually created by the Protecting Access to Medicare Act of 2014. With the objective to transform Medicare from a passive payer of skilled nursing claims to an active purchaser of quality health care for beneficiaries. They want to link these payments to performance on certain quality measures. This program is going to establish some hospital readmission and reduction programs for providers. It encourages those nursing facilities to address readmissions by providing an incentive pool for high performers. And actually beginning in 2018, claims for services are going to be subject to that 2% withhold, with the top score facilities eligible to receive incentives or this amount back, but the bottom having actually some reductions on the amount they would have received. This program is going to be fully implemented in 2019. However, in October of this year, CMS is going to actually begin posting skilled nursing performance scores on their Nursing Home Compare website. These programs really mean that it's going to be very important for skilled nursing facilities to review that existing compliance plan and further focus on quality with rigorous monitoring of their quality measures. And in the next example, we have the Cardiac Care Coordination Model. That's actually very similar to that comprehensive care for joint replacement. It's actually Medicare's first cardiac bundle payment, aims to improve quality, reduce costs associated with select cardiac events. This actually holds hospitals accountable for quality and cost of that 90-day cardiac episode, and depending on their performance, they're going to be eligible for those additional payments from Medicare, or actually even be forced to repay the program. And then not even a year after the CJR model began, they're already expanding that to include those additional procedures, namely the hip and femur fractures. And recognizing that providers are going to need time to adapt to these new models and establish processes, these new rules really going to be transitioned in. They're going to gradually phase in risk. That phase in starts July of 2017, and in full implementation in 2021. Incentives to hospitals, repayments to Medicare, and they may be as much as 20% of the episode. Next, I think we're going to move into describing how to chart a path toward value-based reimbursement, and then we've got 3 key steps for you to follow in implementing these models. But first, we've got another polling question for you, and that is, who in your organization will need the most education and assistance with new reimbursement models? We'll give you a few minutes to answer that.
And we've almost got about 50% response rate, so we'll give you another second to include your response.
That's a really interesting response rate. We got kind of an even split between the people on the phone call, which is great, and executive management and the reimbursement staff. So very interesting. So let's jump right into a couple of really good logical steps that every organization needs to take now to start preparing for this transition. The first is to assess where you are. Do something. The time now is to get off the bench. If we wait, it's going to be too late. I like to think about it if you've ever been to the Gulf Coast, where I like to spend a lot of time with my girls, and you're ever standing on the beach, right there at the edge of the water with your feet in the water, you know that after just a few minutes, the waves will start to take the sand out from under your feet, and you'll start to sink a little bit. So even if you want to just stand still, every now and again you have to step up or move just to stay in the same place. I think that's a really good analogy for where we are in healthcare today. You may be in a position with your organization where you're very comfortable with your market share, you're comfortable with your margins, but even if you want to stay in the same place, you're going to have to move. Also, identify the leaders who can create change within your organization, the people that can build consensuses and that are true influencers. This may require us to check our egos a little bit, but that may be the people on the phone. It may be your executive management, and if so, that's great. But also it could be your nurses, your doctors, your board members, owners, etc. But whoever those people are in your organization that control change, or that can get coalitions of people together, that's who we're going to have to sell this change to. That's the ones that we're going to have to influence and help them understand what's happening so that they can build coalitions behind us. Also, identify an organizational champion to understand the new reimbursement models. I like to call this person a CCO, a Chief Change Officer, but you can call it whatever you want. But basically, I think this should go through one person. The reason for that is the scope and just the volume and the pace of the change that's affecting our organizations is just too fast and too much for every member of your executive management team to try to understand and digest. It's just too much. We need one person whose part of their role is to understand the changes to reimbursement that are affecting our organization, to truly be able to then decipher that and communicate that in terms that everybody can understand to the management team that they can then be acted on. For some organizations, this may be a new role. It may be a new FTE. For most of the people probably on this phone, just due to resource constraints, it's probably going to be another hat that somebody has to wear. If so, that's okay, but it's not a reason to stop. This is definitely something that has to be done. Also, rely on the resources that you have. Just about everybody on the webinar today has trade groups or other organizations that are out there fighting for them. Rely on the expertise that's there. You also have existing relationships with your CPAs, CRI can assist, your attorneys, other advisors. Identify through this process who you can trust and rely on the expertise that's available to you. You don't have to go alone. Next is assess kind of where you are with your risk-based strategy. Every one of these new models that's coming out and that's in effect now and is going to come out in the future has some component of risk-based contracting to it. So a lot of my clients will say, Brian, I don't have any experience at all with risk-based contracting. I don't even know where to start. Well, let's see if that's the case. One, think about it this way. Do you have any self-insurance for your employee health claims? A lot of healthcare providers do. Or do you have deductibles that are very high for your employees? If that's the case, you're already managing, you have a risk-based contract. You're managing the health of a population. It just so happens that population is your employees. So you have experience there. You just need to kind of think about what your strategies are for managing those risks and those costs and think about how we're going to apply it to other populations. Do you have any payers that pay you below cost? Well, if you accept Medicaid, which I think just about everybody on the webinar today does, you have a payer that pays you at or below cost. So that is a risk. For every Medicaid patient that you're getting, you're probably either losing money or getting pretty close to break even. So you have a strategy that you have been living with for managing that risk to your organization. Consider and manage those risks in the financial components that run your business today. The takeaway here is that you have more expertise and experience with this than you may think. So we're not starting from scratch here. Very important concept is that your boards, and you can replace boards with ownership if that's the makeup of your organization, but the boards are going to require training to understand the nature of the changes and their responsibilities and roles. The battle truly will be won or lost in how engaged your board and ownership is. This is table stakes. This is something that you cannot do. You can't do this by yourself. I've seen many good efforts on the part of CEOs and other executive management to try to transition or pivot organizations away from the old way of doing things. I've seen those really good attempts fail simply because management and the board or ownership wasn't on the same page. If you have a community board or you have older ownership, or maybe you have older physician ownership or leadership, it's going to take even more to kind of get them on the same page with you in terms of the change, because reasonably, if you think about it, they're used to doing things the same way for the past 25 or 30 years, and they're going to naturally think that what we've done in the past that's got us here will get us to the next step, and that's just simply not the case anymore. So I think we have one more poll question here for us. How prepared is your organization for the transition to value-based reimbursement as we stand today? I'll give everybody a couple more seconds to get their vote in. Thanks everybody for participating here. All right. So it seems like we've got more than half of the attendees have said that they're somewhat prepared or studying impact. That's great. So everybody at this point, or the majority, has taken the first step, and then we've got next is pretty much just starting now, and that's okay. So Bart, I think, will take us through our next step.
Yeah, really. So what does all this mean? Well, it means that we're really going to have to rethink how we approach patient care. For decades, we've thought of that procedure or service that's provided, and providers have really been on an island where the only thing that mattered is how that patient was taken care of in our facility or office. But these models, they really do require that renewed coordination among all providers involved in the patient's care. Collaboration is going to have to be made between the hospitals and physicians and the skilled nursing facilities and the home health agencies and all other providers. In the new bundle payment models like the comprehensive joint replacement or cardiac rehabilitation, hospitals are financially accountable for the 90-day episode of care. So those hospitals are going to want to work with the most reliable providers of highest quality post-acute care. They want the best nursing facilities, rehab centers, and home health agencies. So those wanting to collaborate with those hospitals are going to need to be able to demonstrate to that hospital the value that they provide. And we've already seen demonstrated what a lack of communication and coordination can do just this year in the CJR model. Nursing homes who didn't understand the significance of that CJR on their therapy and rehab revenue and who didn't collaborate, they saw sizable drops in revenue in a single year, some by as much as 7 figures. So really, it means that providers are going to have to move toward our patient and not just my patient. And part of this is taking advantage of the information that's available. Information, it's plentiful, it's only going to increase. So understanding what that raw data means and using it to your advantage is going to become more important than ever. So that may require some additional in-house resources, additional software, or even reliance on third-party firms. Providers are going to have to perform that assessment candidly on themselves and to know where they are, and they're going to have to analyze their strengths and weaknesses, how they compare to their local competition, and what areas they need to focus on. They're going to need to collaborate with other healthcare providers, insurers, and physicians to share that data to improve their quality. Insurers too, they're increasingly interested in sharing claims data with providers because they believe that this is going to increase quality and reduce costs for them as well. In addition to managing that quality outcomes and the total experience of the patient, providers, they're going to have to be in tune to key performance metrics, demonstrating effective cost management, transparency, effectively, removing those secrets in healthcare providers, mostly with respect to pricing and quality. So we've got to stop ignoring or covering up our deficiencies. Providers are going to have to take ownership of those issues and solve them and communicate them with your patient base. There's a lot of information available to the public, and competitors have that information as well. Those include quality measures, pricing, star ratings, comparison to peers. So competitors are looking at the same data you are, so you will have to assess your ratings and prepare for those models and maintain your competitive position. That information flow is, it's just going to continue to increase, and there really will be no more secrets in the future. The next step, healthcare practitioners will need to be proactive in how they think about and perform care. Simply, that eventual outcome is that providers will be paid for taking care of patients before they get sick or sicker, and they'll be incentivized to improve the health of the beneficiaries and not just treat those symptoms. That approach is very different for the healthcare industry and really is going to require a more proactive mindset. Success is going to be determined on how we care for our patients. It's not in how many patients we care for. So providers really going to have to search for those opportunities to improve the overall health of the patient and community and use that to sell to payers, physicians, and collaborating with organizations. Providers they're going to have to become the best provider they can be and trust that increasing quality will result in greater profits. How often do we hear of the highest quality provider in an area going out of business? That's rare, right? The highest quality provider, they win. Organizations that use that available data to their advantage and are committed to being the best, they're going to have an opportunity to grow and grow their market share. It may seem that these aren't a huge deal now, but I think as we've seen, they're only become more and more important. And that provider that uses them to their advantage, they're going to be the one that wins out in the end. And I think we have one more polling question for you, and that is, who do you usually turn to with questions related to reimbursement changes? So if you will, select an answer there, and we'll give you a few minutes to look over that.
All right, I think we'll go ahead and close it out here. So again, very interesting results. Looks like pretty even split between internal resources, trade groups, and CPA firms, auditors, and others. So that's great. So the next step is, at this point, we've done we've recommended you do a self-assessment, kind of feel out where you are in comparison to what the community needs from you and what your competitors are. But next step here is to fill in any gaps. Every organization, from the smallest to the largest, doesn't matter, is going to have weaknesses and opportunities for growth. If you have, not if, but when you identify the weaknesses and the holes that you have to fill with your resources, first step's own it. No reason to hide anything anymore. Transparency, and as we move closer to transparency and true transparency in the industry, there's not going to be any more secrets. So own your weaknesses, and then more importantly, move to fill the holes regardless of whatever it takes. Make sure you have the resources and ability either internally or somehow available to you in a collaborative network, or even contracted with advisors, CPAs, however you have to do that. Doesn't matter. Just make sure you have those resources and understanding available to you. Next step is IT. I don't want to undersell IT. IT will become more and more a part of our lives and our industry in the future. Give an example, meaningful use is now going to be required of physicians as a prerequisite for MACRA. And not only is it meaningful use, it's the 2015 certified version of meaningful use. Just as, again, as table stakes. It has to be done before you can move into MACRA. So we can't put off IT anymore. However, I would say to resist the urge to overspend on technology. No matter what IT package you've got out there, software package, and no matter whatever the salesperson says, IT can only do so much. Depending on where you are, if you're a large health system that's going through population health management or some type of alternative payment model, you may need software to analyze the big data, quote unquote, that's out there and claims from your insurance organizations and kind of understand what's going on. If you're a smaller healthcare provider, you may not need as much. But no matter what packages we get in the future, the software has to facilitate where we're moving towards. So we need it to facilitate collaboration between healthcare providers, and it may be providers of various types. It may be systems that help hospitals talk to nursing homes, talk to home health. We need to start thinking about it that way. And then it may be a situation where we have to outsource. It may not be where we're purchasing the software ourselves. So just kind of keep all options on the table, but also don't overspend. Just keep in mind you can't outsource organizational change. And finally here, start thinking about cash flow. I know cash flow for most of the people on this webinar is going to be on the top of our mind every day. But anytime you start to go through these transitions with an alternative payment model, Most CEOs expect the finances will suffer up front and cash flow will suffer. So start to prepare for that. Build up a war chest to the extent we can. I know some providers simply don't have the resources to do that. But for our physician friends, I know physician practices typically will distribute all cash to owners routinely, and that's just the nature of how it's been. You're going to have to start moving away from that. It's going to have to keep some resources within the practice that will help you navigate any cash flow disruptions that may happen when you move to these new payment models. If you deem it necessary, once you've done the self-assessment, if you see that there's gaps and there's weaknesses that you just can't overcome internally, pursue clinical integrations and mergers. This has happened a lot in the industry. There's nothing wrong with that. It is not a failure to recognize that you need external help. The failure is to let your doors close because you weren't able to recognize it, or you weren't willing to recognize that. What I would tell you is, if you get to that point where in your organization you determine that you need the resources of a large organization, or clinically you need another provider to fill some of your gaps, don't wait until it's too late. Don't wait till you get to the point where you're negotiating from a position of weakness. You want to be able to, if you see that coming, negotiate from a position of strength. Again, that is not a failure in leadership to realize that you need external help. And then finally, we need to start thinking about it a little more broadly in terms of healthcare. There is still margin, there is still profit to be made in healthcare today, but the margins within your walls may be narrowing. I think hospitals can tell you first and foremost that the margins have been greatly restrained in the last couple of years. Explore other potential revenue generation models. Our physician friends have long understood that if you want to increase the profits of the practice and the distributions to the owners, you need to control the ancillaries. You need to control the lab, the imaging. You need to own that. Hospitals and other nursing homes and other types of providers need to start thinking outside your walls. One really good example is a lot of hospitals and health systems have started acquiring gyms and fitness facilities in their communities. They'll brand them with the hospital. It makes a lot of sense because it's increasing the health of your community, but also there's a healthy margin there. So it makes a lot of sense. Some of the larger health systems, not saying we should do this, but some of the larger health systems have actually started purchasing or affiliating with hotels that are on their campus. If you think about it, if you have a hotel right beside your facility, it is drawing its revenue from you. That is part of the healthcare ecosystem. So that is a natural way that you can cast a wider net and grab more of that margin. That's just a couple of examples, but those are that's how we're going to have to transition our thinking into, well, what can we do outside of these walls to capture a larger piece of the margin that exists in the entire patient encounter, not necessarily just what we've done in the past. Lastly, I'd say reach out to us. CRI can help. We have thousands of healthcare clients all over the South. We've been through this before. This website address that's on here, you can go on here and register, and we'll reach out to you. But beyond that, again, don't think you're in this alone. You have resources available to you via trade groups, your peers in the area, your CPAs, your advisors. Reach out and don't go this alone. In the future, you can look for CRI to come out with some additional information and webinars on potentially specific alternative payment models, and do some specific training, possibly even by industry. But we look forward to helping you through this process. We attend most of the trade groups for most healthcare provider types in the South. If you see one of our booths, come meet us. Give us a call anytime, and we certainly love to meet you and speak with you.
So now we've got some time for a couple of questions. If you'd like to take a few minutes and type a question into the questions pane we will be glad to entertain those and try and give you a response.
Looks like we got a couple here. All right, we have one question here. I'm a hospital executive with a community board. How do I convince my board members what needs to be done to prepare my hospital? That's a great question and a pretty common one. So how do you convince your board, if you're a hospital or really any type of healthcare provider, how do you convince your ownership or your leadership of what you need to do to lead your organization towards change? Well, I'll tell you a couple things. One is repetition. I think it's a good idea every time you have a board meeting or a meeting with your ownership to bring this up, to talk about it, maybe to print out articles and show them. Just repetition can continue to talk about the change that's coming and why it's important that we pivot the organization. Also is outside voices. I think it's important that your board or your ownership hears about the changes from more than just you. I think that'll help them understand the scope of what's coming and really engage and involve them. Bring in resources from your trade groups will do it, your attorneys, CRI. We'd love to come meet with your board anytime and talk about this. But the more voices you can get in there and the more times you can say it will help your board and your ownership to slowly start to understand what's at risk here.
Brian, it looks like we've got another question here. The attendee asked, I have heard that Obamacare is going to be repealed and that all this will go away. When should we expect that?
Okay, that's a very timely question. So day before yesterday, the American Health Care Act was released, at least in proposed form. It's going to change, but having gone through that, the Affordable Care Act is going to be repealed, or at least parts of it. But I can tell you that nothing so far that we've seen is going to affect this move from our industry away from fee-for-service. We've actually, in the American Health Care Act, there's really not one word that would slow down or change this progression. So I think regardless, again, there's broad bipartisan support for these alternative payment models. Regardless of what happens, we feel very confident that our industry will continue to move rapidly away from fee-for-service. I don't think that's going to change.
Thank you, Brian. We do have another question. This is in regard to nursing home value. The question is, you mentioned a 2% withholding on claims beginning in 2018. Will that be a standard withholding on all claims?
Bart, elaborate
yes,
on
actually,
that?
This Bart, yes, actually it will be on all claims that are as part of the value-based reimbursement, as part of the program. So not necessarily all claims, but the ones that are part of the program. And you know, you're eligible to get that money back based on the top performing facilities will be able to get that back, or even more than that. They haven't really released the regulations on how that's going to work just yet, but for now, we know that they're going to withhold that 2% and then potentially incentivize those top performing facilities to get that back.
And Bart, just to clarify, that would only be on Medicare claims at this point.
Yes, yes. Medicare claims that are part of that program.
Correct. And that's very similar to what the hospitals have been going through recently with value-based purchasing and hospital acquired conditions and readmission adjustments. There's a number of these type of value-based models that are hitting hospitals and have over the last couple of years, but that's very similar in terms of the structure that CMS takes a certain percentage off the top of that spend, and then they give it back to you based on how you perform compared to your peer group. So you can get back that 2% that they took, or you can get more than that 2%. But I think what's really interesting about that is that you can see very quickly some of the things that CMS has liked with the hospital industry starting to slide that into the payments to skilled nursing facilities. And we're starting to see that creep into the physician models too. So we can definitely see that expanding very rapidly across the industry.
Okay, I think we've got a couple more minutes for questions if anyone else would like to type one in. One more that's popped up is, how do I convince my physicians that they have to change the way they practice to these reimbursement models?
All right, that's a great question too. Physicians are sometimes the hardest types of providers to convince that we're just going to have to change the way that we provide health care and the way we operate a business. The way that we've done things in the past is not necessarily what's going to work in the future. Again, I think the answer is very similar to what we've seen, or what I said with board and ownership, is it's repetition. It's saying it again and again, supporting it with facts, with articles, showing them what's going to change. Physicians are very much convinced by facts, by articles, by logical arguments. So showing them that it's going to change, and again, multiple voices. Bring in your trade group, or have your physicians go to MGMA or some of these other type of events and see with their own eyes what's changing. Bring in CRI, of course. We'd love to meet with your practice and discuss with your owners what's going to change. But they will, especially some of the older physicians that have practiced this way for a number of years, are going to require a good bit of convincing that what they've done in the past is not necessarily what's going to work in the future. I think that's about it. If we have, if there are any questions that we weren't able to get to, we'll reach out to you directly. And if you have any questions at all for us, we have our contact information right here. Please do reach out to myself or to Bart. We'd love to speak with you, and we'd love to answer anything we can. And also, please do register on the website. That'll help us keep in contact with you, and you can text CRI to the number at the bottom of your screen to get news and alerts. But we'd love to help your organization. We appreciate your attendance.
And as a reminder, the recording from this webinar will be made available within 24 hours. And we hope that you'll join us again in the future for more webinars. Thank you.